Hi, my name is Mark Haber. I'm a clinical associate professor at the University of Wollongong and a shoulder surgeon. I work out of a number of clinics, including Southern Orthopaedics in Wollongong, Campbelltown Private Hospital Clinic, and a few clinics around Sydney, these including Sydney Sports Medicine Centre Homebush, Macquarie University Hospital at Macquarie Park, and Lady Davidson Hospital in Turramurra. In this talk, I'm going to discuss the rehabilitation following rotator cuff repairs, and in particular, a case such as this, where a retear of the repair has occurred, because the most common problem or complication following rotator cuff repair surgery is retear. And it is quite common, up to, in this study, 94% of patients with large and massive tears, but still sits around the 22% of all rotator cuff repairs retear. So the aim of this study is to discuss why do rotator cuffs tear in the first place, how do we perform rotator cuff repairs, the natural history of rotator cuff tears, how do they heal, and ultimately the prevention of retears during the rehabilitation. So why do rotator cuffs tear in the first place? The etiology is thought to be two main factors, extrinsic and intrinsic. Extrinsic causes were first thought to be due to what we call the impingement syndrome, which was described by Charles Neer in 1972. He described, and I quote, proliferative spurs on the undersurface of the acromion, apparently caused by repeated impingement of the rotator cuff and the humeral head, led to partial tears that in turn led to full thickness tears. This is an example of a primary impingement, where the rotator cuff in the bottom impinges on the undersurface of the acromion. And that led to Bigliani's study describing different types of acromion, with the curved or the hooked type acromion causing more tears. We don't really think along these lines anymore. Other extrinsic causes of rotator cuffs include mechanical factors such as history of trauma and engage in heavy labour. But age and this factor was still seemed to be shown to be a major factor. So that brings apart the intrinsic or degenerative microtrauma model. It is thought that age-related tendon changes, chronic microtrauma, and reduced circulation lead to partial tendon tears, ultimately full thickness tears. It's a progressive tendon damage, a vicious cycle, and I use the analogy of this piece of rope. As each fibre of this rope tears, every other remaining fibre has to carry more loads till eventually they all tear. And this is an example of an arthroscopic picture of a torn rotator cuff. And we can see that the rotator cuff itself is extremely degenerative. It's in fact very rare for healthy tendons to tear. They are usually in a very degenerate state. So the next thing I wish to discuss is the natural history of rotator cuff tears. We know from studies of the natural history of asymptomatic rotator cuff tears that is very underappreciated. It is not a benign disorder and has major consequences of ongoing management. So the asymptomatic tear in the younger tennis player is unlikely to remain so as this man grows older, and will compromise ability to remain active throughout his life. This was well demonstrated by Yamaguchi in 2001 when he did ultrasounds on the contralateral asymptomatic shoulder of patients presenting to his clinic. Nearly 40% of these patients had asymptomatic tears. The interesting point is half became symptomatic over a 3-year period, and over that period nearly half of those tears progressed in size. So our whole concept of asymptomatic doesn't matter and let lying dogs lie doesn't necessarily hold true. It's a bit like dental decay and atherosclerosis of your arteries. It can progressively get worse and monitoring is required. So he concluded the size of tear is an important factor in the development of symptoms, and tears tend to increase in size in an unpredictable rate, and therefore recommended surveillance ultrasounds at least at yearly intervals of known rotator cuff tears which are treated non-operatively. In another study looking at full thickness tears, prevalence and correlation with function and comorbidities in age 65-year-olds and older, this study showed that subjects were scrutinied from an orthopedic lower extremity clinic, in other words, were not presenting to the doctor with shoulder problems, and ultrasounds were used to assess their rotator cuff status. In this cohort, there was a 22% prevalence of tears, and shoulder scores were poorer for those with tears, whether they were symptomatic or not. Another study looked at the tear risk factor for tear progression, and the main showed that age over 60 and size were the risk factors. So, more on the issue of tear progression. Tear progression generally starts from a tendonitis onto bursitis, partial tears and complete tears. And throughout the rotator cuff tendon, it's the supraspinatus that most commonly is affected. So, looking sagittally at the supraspinatus, it has an approximately 15mm attachment to bone from medial to lateral. Initially, degeneration occurs within the tendon, and finally, detachment of the tendon occurs. The tendon is non-retracted and is only partially torn, and in this example, from the articular or medial side. It may also happen from the bursal surface as well, but it's still non-retracted until it completely detaches off the bone, and that's when we call it a full thickness retracted tear, and the retraction increases over time. The tear tends to occur at the anterior aspect of the supraspinatus, and as the tear gets bigger, it may go on to involve subscapularis in the front and infraspinatus in the back. The AP distance becomes bigger, as does the medial lateral, or as we described, tendon retraction. And ultimately, once the tear is large, it no longer contains the humeral head, and upward migration occurs. This is another diagram demonstrating that. There's a constant pull from the deltoid, pulling the arm up. And this is counteracted by the rotator cuff tendons, which hold the ball in the socket, pulling the humeral head down. If the rotator cuff tendons fail, the deltoid has no resistance against upward migration, and subluxation of the humeral head upward occurs. And once the tendon retracts further and further, and I'll talk more about that, but in an anatomical of the shoulder replacement. So how do tendons heal? It's a major issue. Typically after surgery, there is hemorrhage, and then an inflammatory phase starts at about approximately 7 days. A proliferative stage starts to occur about 3 weeks after the repair is performed, and a maturation and remodeling phase starts to occur at about 6 weeks after surgery. One must remember these are animal models, and there's huge variations even amongst species, never mind individuals. So, after the hemorrhage occurs, platelets enter and initiate clot formation. At this early stage, it is the sutures which hold the tendon against bone, because all there is blood, fibrin and platelets between the tendon and bone. During the inflammatory phase, chemotactic mediators attract white cells. Fibrin cross-links collagen with collagen, and this forms what we would describe as a fragile bond. This may start at 7 days, but it's weeks before even a fragile bond appears. But then the chemotactic mediators attract inflammatory white cells, and which is why we do not like to use anti-inflammatories at this stage. When the proliferative stage and new cells form, granulation appears around the original clot, and fibroblasts initiate haphazard production of collagen. The repair starts to grow stronger during this phase into the maturation stage. The repair grows stronger during maturation, begins about 6 weeks after surgery, where scar organises, immature collagen becomes type 1 collagen, aligns with tensile forces, and remodelling into permanent repair tissue is formed. These are animal models with huge variations. Repair of the rotator cuff has been studied in many different species, but they do not form a true rotator cuff. This is solely in advanced primates. And as David Sonneman said in his paper, there is limited scientific evidence to assist surgeons in developing regimes for post-operative rehabilitation. It's mostly empirical, relying on clinical studies, which are often animal studies. In his study, he used middle-aged baboons. However, one must remember their tendons were essentially normal. They were not degenerative, as opposed to cuff failure in man, where degeneration really does occur, where tears occur in degenerative tendons. Anyway, these animal models represent a best-case scenario for our repairs. He had 8 middle-aged baboons. 2 were killed each at 4, 8, 12 and 15 weeks post-operatively. The bone tendon repair zones were assessed macroscopically and histologically. Interestingly, watching the baboons, they did not move their operated shoulder voluntarily for several days. They avoided climbing for about 3 weeks, but by about 8 weeks no noticeable difference in use was detected between the operated and non-operated arm. This would be twice as good, I would say, as our best patients left to their own devices. At least at 4 weeks, the specimens showed bone tendon healing was immature. Between the tendon bone, there was necrosis and hemorrhage and fibrin clot. One can think that the sutures were still very important in this type of repair. At 8 weeks, macroscopically, the repair appeared to be healed, but there was no Sharpie fibres. At 12 weeks, we could see Sharpie fibres beginning to appear across the granulation tissue, joining tendon to bone. And by 15 weeks, almost but not quite mature reconstruction of histology. The tide marker occurred, and Sharpie fibres were crossing from tendon to bone. So, in summary, healing of the baboon: 4 weeks healing immature, 8 weeks appeared healed but was not. 12 weeks we started to show Sharpie fibres starting to appear, and in 15 weeks we saw bone tendon junction was almost but not quite mature. If we double this in the human as a rough guide, we could suppose that by 8 weeks the healing was immature. By 24 weeks, Sharpie fibres appear in considerable numbers, and by 9 months, almost but not quite mature healing. So David Sonneman summarised by saying the results support the use of a post-operative rehabilitation program in man, which protects the surgical site for at least 12 to 15 weeks in order to allow maturation of tendon to bone healing. We can use retears as a test for this hypothesis. So how do we prevent these retears? Because retears can teach us a lot about our failures. And as we stated earlier, retears are common, with papers showing tears up to 94% in large and massive tears, but even studies more recent show tear rates of 24–22%. Some studies showing as good as 11%, but this is only very select patients, and we are showing that more recent and better repairs are showing lower instances of retears. So let's look at the cause of retears. There are mechanical factors, poor quality tendon or bone, which may result in early loss of contact, or techniques which do not reconstruct the tendon bone surface areas. But there are biological factors which result in late tendon to bone contact, or inappropriate rehabilitation. All of these result in failure to heal. So in the study, we looked at intraoperative findings in patient retear following arthroscopic rotator cuff repair. The aim of the study is to look at who is at risk, when did the retears occur, and how can we readjust our rehabilitation protocols based on this information. So many studies have shown postoperative imaging to evaluate rotator cuff integrity. Most have used MRI or ultrasound at a single time point. We have very limited studies looking at tendon healing over time with serial ultrasounds. Feely, Noah and Miller are three good examples. Small numbers compared to this study, where we looked at 608 patients. Average age of our patients was 59 years old. 26 were bilateral procedures, but all the procedures were performed by a single surgeon in a single hospital with a standard technique. The demographics are shown here with a huge preponderance of males between 50 and 60 years old. We looked at a number of intraoperative findings, including patient age, tear size, bone quality, retraction degree, and repair tension. And I've already discussed the importance of tendon retraction. That is the distance that the tendon has retracted off its anatomical attachment. Patients were analysed at 6, 12 and 26 weeks. And retears was assessed using an ultrasound. And the relationship between age, intraoperative findings and retear at these time periods were investigated. Ultrasounds were required and interpreted by a single musculoskeletal ultrasonographer with huge experience in shoulder ultrasound. He looked at full retears versus partial retears. And here you can see, for example, in rehabilitation after 6 months, and I'll explain why that's so risky of the tear. We showed that the first 6 to 12 weeks, why is the question we're trying to answer. The same cohort I've discussed previously. Results. We divided patients into the patients that will retear versus patients who will not retear. At the 6-week review, when the patients were intact, but Group A were patients who will retear at 12 weeks versus B, patients who will not retear at 12 weeks, one would have thought the patients who will retear had poorer outcomes at that stage than patients who will not retear. We found the opposite. At the 6-week review, when the patients were intact at 6 weeks but will retear at 12 weeks, they indeed had less pain than patients who will not retear, who had more pain. The same can be said at the 12-week review. These patients were intact at 12 weeks, but the patients who will retear by 26 weeks versus patients who will not retear by 26 weeks, again, the patients who will retear at 26 weeks had less pain than the patients who will not retear, who had more pain. So, putting it through our pain scoring system, we had big variations even at 12 weeks with mild pain to severe pain. The same can be said at 26 weeks with high pain levels, low pain levels. The patients with the better scores and less pain tended to be not intact, and the patients with more pain and were unhappy tended to be intact. These same findings were noted at the 12-week period. But at some stage it crosses over. The patients who were not intact versus patients who are intact swap over, and the intact ones become more happy and the non-intact ones become less happy. So, these results show that clinical outcome scores in patients prior retearing are better than patients that retear. Scores for patients with a retear were significantly higher than patients that did not retear even before the retear occurred. The question is, why is it so? Is it simply a question of compliance, or are there biological issues? there are patients with low healing capability, and this is a case of healing failure rather than repair. Chelemy in 2011, considering the dermographic information, tear severity and miscellaneous data, it is possible to predict the rotator cuff repair at risk. The rotator cuff which will be able to heal. So, do we see less pain in the non-healers? Is it a lack of healing response associated with less pain? Or is it simply a failure of compliance, where they had less pain, they were less compliant, and therefore tore? These outcomes suggest that post-operative rehabilitation needs to be altered depending on patient recovery from the surgery. And it is extremely important to stress the importance of compliance. So, the 6-week patient who comes in with great range of motion and minimal pain is the patient who is at risk. They either have retorn or will go on and retear in the future. So the conclusions from the study. Favourable early recovery can be indicative of impending tear, and this stresses the importance of customising the rotation. Charicet, looking at constant scores, differentiated between the watertight healing and the retear patients. And he noticed it was about 12 months after surgery that the differences became significant, and the patients with good healing started to outperform the patients who retore. And it was 12 months or later before he demonstrated a significance between these two populations. So, is it a biological issue? Chelemy in 2011 looked at rotator cuff retears or non-healing histopathological aspects, predictive factors. He looked at the histopathology of ruptured tendons, and he noted that they were in disarray. That is, they had loss of structural organisation, poor or absent neoangiogenesis. In other words, poor new blood circulation, and chondral metaplasia and fibrosis. That the tendon had metaplased into more chondral and fibrotic tissue. And he felt this gave the tendon tissue a low healing capability. And therefore he described healing failure rather than retear, and the new concept of the non-healing. And he noted that the probability of healing increases in the presence of inflammatory cells in the bursa and neoangiogenesis in the tendon. And this was noted with the decreased patient's age. Comparing the histopathological data, demographical information, and descriptive statistics, he felt it was possible to find the rotator cuff repair at risk and identify which rotator cuff will be able to heal and which one not. So, is it the lack of healing response is associated with less pain, or is it a compliance issue? These outcomes suggest that post-operative rehabilitations needs to be altered depending on the patient recovery from surgery, and the compliance is critical. This patient is at risk. Favourable early recovery can be indicative of retear, and these findings are helpful in customising the rehabilitation. In a further study performed by Dr. Ahmed, our fellow at Macquarie University Hospital, he looked at retear of the repaired rotator cuff, who, when and why. He again investigated the demographics in our database, gender, age, intraoperative factors and postoperative factors. And one of the things he noticed was the issue of compliance. It seems to be that at the 6 to 12 week mark, compliance became a major issue. We could see the patients who were partially compliant, therefore partially incompliant. These were mostly noted at the 6 to 12 weeks. On serial ultrasounds, on this study, when we had reduced our activities in physiotherapy at 6 to 12 weeks, we noticed that at 0 to 6 and 6 to 12 weeks, there was no significant difference in the retear rates. But after 12 weeks, the retear risk significantly reduced. So, retear summary. Who retears? The intraoperative findings are cuff retraction and repair tension. The post-operative factors who put the person at risk of tearing is a patient with less pain and poorer compliance. There was no significance, however, associated with gender, age of the patients, AP size of the tear, or bone quality. When do they retear? More common in the first 3 months, and much less between 3 and 6 months. And after 6 months, it was safe. Retear incidence was highest between 6 to 12 weeks. Why do they retear? This can be divided into surgical technique, the biology, with failure to heal, and compliance and appropriate rehabilitation. So, I used to think about rehabilitation protocols as not an important issue. Used to bury my head in the sand. Now we've taken a much more go slow. It's a bit like the hare and the tortoise. Because when we decide on our rehabilitation protocols, it is always a compromise between stiffness versus healing. So we have two sorts of patients, the good healers and the poor healers. Of those, we can divide them into the stiff healers. If the patients are good healers, we can try and be more aggressive with stiffness. However, if the patients are poor healers, I think we have to compromise on the stiffness issue and go very slow on the rehabilitation. There are a number of papers looking at the rehabilitation and cuff integrity and recovery of motion, such as this one by Deutsch in 2007. And he showed that a decelerated rehabilitation resulted in fewer recurrent tears and did not result in increased stiffness. Parsons asking the question, does a slower rehabilitation after arthroscopic rotator cuff repair lead to long-term stiffness? And he concluded that it does not lead to long-term stiffness, and indeed there was a trend towards improved tendon healing in patients observed to have early stiffness, very much in keeping with study. Lee in 2012 looked at rehabilitation protocols on range of motion and healing rates, and he noted in the aggressive group there may have been improved, more rapid recovery of movement at 3 months, but at 12 months there was no difference. But the aggressive group had an increased possibility of anatomical failure. And Cuff and Papello in 2012 looked at early versus delayed postoperative physical therapy protocols. They demonstrate also similar outcomes and range of motion at 1 year between the groups, but there was a slightly higher rotator cuff healing rate in the delayed rehabilitation group. So, I believe it's important to customize rehabilitation protocols. In the phase 1 or the immediate postoperative period, we have minimal motion. For the first 6 weeks, very gentle, passive range of motion. During phase 2 of the protection and passive range of motion only, this is between 6 and 8 weeks. In the protection and active range of motion, I would recommend starting that ranging between 8 and 12 weeks, depending on what sort of patient you're dealing with. Early strengthening starts anywhere between 12 and 24 weeks. I would certainly delay strengthening in the high risk of retear patients. And advanced strengthening should start anywhere between 24 and, in the high risk patients, 52 weeks. I'd like to thank you very much for listening to my presentation.